students, in today's module we will be discussing about diagnosing and assessing psychosocial difficulties in older adults. You all know, to understand the physical well-being or the mental well-being, the first step is the proper diagnosis, which can happen with the assessment. So, if it is a physical illness, there are certain physical medical checkups. If it is a psychological issue, naturally we try to assess them using various techniques like questionnaires, self-reports, rating lists, checklists, rating scales and various other devices. When it is easy to use these diagnostic tools and provide an assessment related to the children or the adults or the adolescents, doing the same kind of a diagnosis and assessment with the older aged people is more challenging because of various issues, like probably they may not be able to hear or they may not be able to comprehend due to the cognitive impairments or the decline in the cognitive functioning, or sometimes they need a support to respond to an interview or to a checklist or to a questionnaire. So, they need someone who can help them out in understanding the things, in understanding the questions that are asked and then rating. So, how important it is to diagnose and assess the psychosocial difficulties in older adults will be discussed in this module. In diagnosing and assessing psychosocial difficulties in older adults, American Psychological Association has designed guidelines for psychosocial practice with older adults. Guidelines indicate that assessment tools should be appropriately validated and normed for the proper usage with the older adults in order to determine social, emotional and cognitive functioning of older adults. Sometimes longitudinal assessment is also useful, particularly with respect to those matters like older adults' affective state or functional capacities, and we can help in examining the degree to which these are stable or varying according to the situational factors, time of the day and similar other reasons. Other special challenges in assessing older adults include interpreting the significance of somatic complaints. Sometimes we see that oldest people go on complaining some problem or the other. So, whether they are genuine or psychologically they are feeling it. Appraising the nature and extent of familial and other social support. So, it is very difficult to indicate whether they are having a proper support or not. Evaluating potential elder abuse or neglect. This is very difficult to really identify unless there are some obvious signs on their body or in their words, or if they are able to really genuinely express it through their body language, only then it is easy to infer or identify the proper abuse that has happened. Identification of strengths and potential compensatory skills. So, these are the challenges which we feel in assessing the older adults. Assessments may also affect the efficacy of treatment, and knowing when referrals to nursing home and daycare programs are most appropriate. If the assessment has not done effectively, then probably the wrong diagnosis may take place and we may not be able to send them to a proper referral where they can really get the proper treatment. Recognizing emotional problems in older adults poses additional challenges. So, many people they do not express it. We need to infer from various other indices or the other signs that we are able to observe. Because of the complex relationship between emotional problems, drug interactions, that is if they are on the medication, and serious physical illness in the elderly, an accurate diagnosis is not always straightforward or possible. So, sometimes due to the emotions they may not be able to give the proper responses, or because they are under the medication they may not be alert to the questions that we are asking, and sometimes the physical illness may be disabling them. Some older adults may be aware of their emotional difficulties, but believe that nothing can be done about it, or they may only report physical symptoms like aches and pains. They do not want to share what is happening with their family members. Their symptoms are ignored or confused with other ailments common in the elderly, including Parkinson's or Alzheimer's disease, dementia, thyroid disorders, arthritis, strokes, cancer, heart disease, medication and other chronic conditions. Depression may also be a predictor for Alzheimer's disease or an impending physical illness before the symptoms of the disease itself become evident. To take a proper accurate diagnosis, a researcher by name Cloud in his study conducted in 2003 suggested 4 categories of disorders. Those arising from brain disease, another set of disorders arising from problems controlling one's drive, disorders that arise from problematic personal dispositions, that is the personality, and those arising from life circumstances. So, life circumstances are not completely under the voluntary control, they are external factors. The guidelines for psychological practice with older adults of the American Psychological Association listed the following inaccurate stereotypes of older adults that can contribute to negative biases and may affect the way an older adult is viewed diagnostically. You know that for every age or the gender, stereotypes prevail in the society. Similarly, the oldest people are not an exception to work or to be perceived from the stereotypic point of view. So, in understanding and assessing the oldest people, these stereotypes that are prevailing in the different cultures or in different societies will also be impacting whether we are properly diagnosing or assessing the oldest people or not. Let us see what are those stereotypes. The first stereotype is, with age inevitably comes senility, that is the old age will be impending. Second stereotype, older adults have increased rates of mental illness, particularly depression. So, not necessary that can happen with all the oldest people. Third one, older adults are inefficient in the workplace, but now if you see the statistics, in most of the companies even the oldest people are competing with the youngsters and then performing much better than the young people. Most older adults are frail and ill. Fifth stereotype is older adults are socially isolated. Sixth stereotype is older adults are inflexible and stubborn. So, such stereotyping viewing of the oldest people can lead to misdiagnosis of disorders and inappropriately decreased expectations for improvement. That is, the clinicians may experience therapeutic nihilism. That is, the clinicians may feel we cannot, whatever the intervention we give, we cannot bring much improvement among these people because of the existing stereotypes. And as a result, what happens? It leads to the lack of preventive actions and the treatment. Badly informed therapists may assume that older adults are too old to change or less likely than younger adults to benefit from counseling and psychotherapeutic services. Some health and mental health professionals may avoid working with older adults because it creates discomfort about their own aging or their relationship with parents or other older family members, and this leads to a phenomena called gerophobia. So, they are not comfortable treating the oldest people, talking to them, either because their experiences with their own oldest parents or other family members may be haunting. Smyer suggested that in assessing older adults, we should use a transition approach which believes development occurs throughout the lifespan. And this approach contradicts the previous therapeutic pessimism which equated old age with rigid defenses, lack of therapeutic motivation and generally poor prospects for change or growth and a time of life not worthy of therapeutic investment. So, when we think about the lifespan perspective, definitely old age is seen in a negative way and they feel much improvement cannot be expected from the oldest people. But when we are using a transition approach, the perspective will change not only for the oldest people, but also for the clinician and the therapist. Smyer also developed a typology of potential transitions containing 4 types of life stresses. Biological stresses which may happen at different perspectives, biological stresses which can happen at different stages of the life, personal or psychological issues experienced at different ages, physical or environmental factors and socio-cultural factors. All these factors can produce some amount of stress at different lifespans, probably including the old age. Smeyer also identified 14 different contexts in which life events occur, including family, love and marriage, parenting, health, self-development, friendships, social relations, finances and work. Trying to understand the background for the need of the psychological assessment to identify the psychosocial issues and the challenges that are involved in the diagnosis and assessment of the oldest people. Now, let us see what sort of errors may occur if proper assessment and diagnosis is not happening. What are the errors in the diagnosis? Number of studies were conducted in assessing the oldest people and making a effective diagnosis. There are certain amount of errors are bound to occur in different contexts. Groupman, who has conducted a lot of research in this area, especially in his 2000 study, reported 3 primary errors that are bound to occur in diagnosis. The first error is anchoring. Anchoring means clinicians grab on to the first symptom or abnormality and use it to make snap judgments about the client's condition. So, just looking at the superficial symptoms, I try to infer or I try to judge or conclude about the illness, whether it is physical or mental. The second error is availability, that is an easily remembered prior experience with a client, that is a memory that is most available to the clinician, is used to explain a new situation the clinician is trying to diagnose. That is, immediately they relate. If a oldest person comes and tries to share some kind of the symptoms, the known clinician, it could be a family doctor or a family therapist, immediately they relate it to the earlier experiences which they have noticed. That also may lead to the errors in the diagnosis. The third important error is attribution, that is, clinician is diagnosing from the stereotypes. We have just discussed the stereotypes that exist with regard to the oldest people. So, judgment or assessment has been done using those stereotypes. So, this is the most common error which is bound to occur in the diagnosis of the oldest people. This error, that is attribution, is more likely to harm older adults because many of us harbor untrue preconceived notions about aging which occurs because of the stereotypes in time. Another serious error in diagnosis relates to the views on race. Especially if you see in the Western culture, race affects the way we interact with the people, like blacks and whites. So, Whaley believed that the diagnostic process with African American clients tend to discount the negative impact of racism and leads to diagnostic judgment about black clients, implying that they are more dysfunctional than they really are. A person with a black race has come for a mental health support. The therapist immediately looking at the race feels it is very difficult for them to change, or all the people from this community behave like this. So, they try to use the stereotypic kind of thinking, and the treatment may not be effective or the wrong diagnosis might happen. This tendency to misdiagnose or to diagnose a more serious condition than may be warranted is called as pseudo-transference. So, I already have some preconceived notions about a particular caste or a community or a race, and based on that I am trying to do the diagnosis. So, this leads to the pseudo-transference. Cultural stereotyping may also lead to more severe diagnosis and restrictive interventions. Research suggests that clinicians may incorrectly use diagnostic labels with the clients they either feel uncomfortable, or with cultural differences they create some degree of hostility, casting doubt on accuracy of diagnostic labels with an entire range of older clients who may differ educationally, racially and culturally from the clinicians. So, the subjective bias may happen a lot when clinicians are treating or assessing the oldest people, especially if they are from a poor socio-economic status or from a different culture whom they don't like, whom they don't admire, there is a possibility, high possibility that the diagnosis may go wrong. All these concerns reinforce the subjective nature of the diagnostic process in general and the usage of DSM in particular. There are certain limitations that people have pointed out with regard to the DSM. Whatever stereotypes that are involved in assessing, all these views are reinforcing the point of the view that DSM is also in certain cases assessing the patients from a personal point of view or a subjective point of view. Croskery believed that most diagnostic errors occur because clinicians make decisions too early and without enough support or evidence to diagnose. These errors are called as representative errors, as they are based on what clinicians were trained to observe and believe, and therefore, they tend to overwhelm an observation with preconceived beliefs about a person and what may be wrong. Another type of bias is self-confirmatory bias or diagnosis based only on the information collected by the clinician that confirms his or her original diagnosis. That is, like the moment I saw the patient, I formed an impression that these could be the reasons or this could be the problem. So, whatever questions I ask, I try to ask those questions which are consistent with my own preconceived notions. A research study also indicated that majority of trainee counselors, that is almost 64% of them, wanted to ask those questions which confirmed their original diagnostic impression of the client. Another type of bias that provides incorrect diagnosis among the older adults is confirmation bias. That is, clinicians confirm what they believe by ignoring or selectively ignoring certain information about the client. So, I already made up my mind that this is the disease or this is the problem that the oldest person is encountered with. So, I wanted to confirm that rather than taking the other additional information. Groupman also stated, when people are confronted with uncertainty, they are susceptible to unconscious emotions and personal biases, and they are likely to make cognitive errors. When it is not possible to predict properly or make an accurate diagnosis, whatever is there in my unconscious, whatever my emotions are speaking or whatever my personal biases are, accordingly I would be assessing them or rating them or diagnosing them. Once we have seen the errors, then how or what methods can be used to reduce these errors? There may not be complete foolproof method, but at least the errors should be minimal. So, let us discuss the ways of reducing the errors in diagnosis, and this has been mentioned McLaughlin in his 2000 study report. He gave a number of suggestions. The first suggestion is, don't make too much or too little of the evidence at hand. Second one is, note the biasing effect of your workplace that may routinely diagnose everyone in the same way. So, if we see 2 or 3 common symptoms among 2-3 people, immediately we rate all the people suffering with the same kind of an illness. So, we should stop that. Try and disprove a diagnosis. Fourth one, consistently use all the DSM diagnostic criteria and keep current about revisions that are happening. Fifth strategy is, be aware of other disorders or a dual diagnosis and delay making a diagnosis until you have more data. Without gathering information about the patient, let us not immediately come to the conclusion. Sixth one, use symptom checklists to make certain your diagnosis adheres to DSM categories and follow a protocol to collect and evaluate data before finalizing the diagnosis. Seventh strategy is, if you use psychological instruments in diagnosis, see that they are valid questionnaires or self-reports or interview schedules, and they are also reliable with the type of the client you are diagnosing. That is, the questionnaires which we are using should be related to the age of the client, gender, ethnicity, etc. Make certain your expectations of clients do not reflect racial, ethnic, gender, religious bias or self-fulfilling prophecies about certain categories of diagnosis. Ninth method is, remember the importance of social factors in diagnosis and that DSM may have a built-in bias with regard to certain groups. Already we discussed about the limitation of DSM. Consider other diagnostic possibilities and understand that the more time you take getting to know the client, the more likely to arrive at a correct diagnosis. If you just look at the client without spending much time with the client, if you go on prescribing or if you go on writing the psychological report, that becomes an invalid report. So, spend some time to collect accurate information from your own observation. Consider the pros and cons of a diagnosis before formally using it with a client. So, whether it is age appropriate, whether it is gender appropriate, whether it is situation appropriate, we have to check that. Next method is use multiple diagnostic instruments to determine a diagnosis and accept a diagnosis only if those instruments are in agreement with one another. You cannot use completely extreme instruments or extreme measures. So, whatever we are using to check the physical illness or the mental illness, they should be consistent or related to one another. Focus on what may be atypical about a client and follow those leads to help determine a diagnosis. Another important aspect is we need to follow the ethical standards. We should not deviate from it. Use training to improve your diagnostic work, particularly with diverse ethnic and cultural groups. All the instruments, all the questionnaires may not be acceptable to all the various cultural groups that are existing. So, we have to check with that. Another way of reducing the errors in the diagnosis is using the grounded theory. Glacier found that grounded theory can be one way helpful to the clinicians to make accurate assessment of the client. What happens in the grounded theory is we are not testing a predetermined belief, that is a hypothesis. Instead, we are trying to come up with a theory about the client and the current problem the client is experiencing. So, diagnosis develops through different steps in the grounded theory. First, we need to collect sufficient information about the client, that is the old aged person, including the current functioning, how his basic functioning is, the physical, emotional, social functioning, past functioning, earlier how he was or she was, and the client's theory of why he or she is experiencing difficulty now, because they may have their own self-narrative report. Then take notes which will clarify the information which we have collected and refer back to the notes to see the pattern or themes in the information collected. So, once we make a report, once we try to analyze, some themes may come out of that analysis. To help see the patterns and themes in the information collected, we need to create categories of issues, problems and patterns. So, what are the common issues that we are seeing in this individual since 1 week or 1 month or 15 days? What are the most repetitive problems that the person is experiencing or the new problems that are coming up, and then the patterns or the themes which we can emphasize upon. The third step is summarize the patterns and themes so that an emerging theory about the client develops. That is, the patient is suffering with so and so disorders or the diseases because of the following symptoms or because of the recurring evidence of these particular symptoms. So, once the theory is developed about the patient, test that theory against accumulated information to see if themes and patterns are persisting. Then begin to consider a diagnosis that, while theoretically accurate now, may change as more data is collected. The next step is test the diagnosis by determining whether it is fitting the situation and whether it is helping the patient make sense of their experience and manage their lives more effectively. The seventh step is have a way, that is a method to double check a diagnosis. That is, if you are taking an interview, record that and then check that data with the questionnaire information that you got, so that there can be, we can see the correlation or consistency in the information that we got. You can also ask another colleague of you to analyze all this data, so that whether they are also coming up with the same kind of a theme or a pattern which you have seen in analyzing the report of the patient. The eighth step is frequently ask the client to provide feedback on the information accumulated to see if your data is accurate. So, periodically check with the patient and obtain more and more information by asking questions, so that whatever you have analyzed, whether that is consistent with the information given by the patient or not, can be seen. Then diagnostic checklists can also be used in order to reduce the errors. Gawande in 2007 reported significant benefits of checklists in hospital settings. So, these checklists can be very brief and short. Asking the physicians to abide by several important questions posed about their practice towards these patients, the infections from these emergency rooms and ICU facilities can be reduced, length of stay in the facility, long term improvement in conditions, and number of other important areas of concern to medical practice can also be increased or reduced depending upon the situation. So, how a checklist can determine the psychosocial functioning of the older adults? When we use a checklist, we can check their past and current illnesses, any accidents that they have experienced. Generally, in the old age, accidents at home, that is falls at home, might be more, disabilities that they are suffering with, surgeries, emotional problems, or past counseling if they have gone for any counseling, previous hospitalizations and medications, all these things can be noted down. Another important point is, have the client bring all the medications they are taking for the initial interview. So that what happens is, we will be knowing like what medicines they are using, what vitamins they are using, for which purpose they are using, all this information can be gathered. If possible, have the client's physician write a brief history of the client's current medical conditions. So, even if you have to provide any counseling, the physical report will also help us whether a particular medicine is giving a side effect in creating the psychological turmoil or an emotional turmoil like depression, that can be cross checked. Check on sleeping problems and length of time the patient sleeps. So, sometimes they might be oversleeping, or generally insomnia will be more common among the oldest people. So, how frequently they are sleeping, what are their sleeping spells, all these things can be checked. Check for language problems, hearing problems and memory loss, as they are very common in the old age. We also need to check how the client spends his day, that is how the oldest person is spending the daytime and the activities that they are engaged, the leisure activities, the recreational activities that they are engaged with. So, that will give a profile of how they are actively functioning or not. Find out the type of housing the patient owns or rents, who if anyone lives with him or her, the cost of it and the client's satisfaction with his stay and the ability to pay for it. If it is a rented house, whether they are able to pay, whether the house is accommodative, are they satisfied with the kind of housing that they have. Ask the patient to bring financial records to determine the client's current financial state. We can also ask the client to bring a spouse or a friend to provide additional information about the client's life. Then get a complete psychosocial history, including the current problem, the duration, and what the client has done to resolve the problem. Another important step is, we need to get a complete past and current history that is related to the family, including the relationship with the parents, siblings and the children. Check for past work experience, satisfaction with the work, and whether the client works at the present. So, all this information will be reflecting the level of functioning, that is social functioning, cognitive functioning and emotional functioning of the oldest person. We can also get a general life satisfaction indication from the client, because generally in the old age when they analyze their life, some of them will be very happy and satisfied with the way they led their life, and some of them might be in despair. So, we will be knowing their levels of despair or satisfaction. Also check the client's religious beliefs and practices. Then need to check suicidal tendencies in order to curtail such kind of attempts. in case if they have that kind of a suicidal ideation. We also need to check for alcohol and drug usage. There is necessary to find out about friends and if the client feels isolated or friendless. We also need to see that whether the clients are associated with any other kind of vulnerable diseases like STDs and HIV or AIDS. So, friends, in today's module, we discussed about main psychosocial difficulties which are experienced by the oldest person. What are the difficulties that are involved in assessment and the diagnosis, different types of error that occur while making this assessment, the challenges that we encounter during this process, and how those can be minimized by using certain strategies and using a grounded theory and by using certain short checklists in the proper diagnosis.